Testicular cancer. Background: 95% of testicular cancers are germ cell tumors. 50 to 60% of germ cell tumors are seminomas, and 40 to 50% are non-seminomas. Of the non-germ cell tumors that make up 5% of testicular cancers, you have Sertoli cell tumors, Leydig cell tumors, and rhabdomyosarcomas. Of note, 85% of all seminomas are stage 1, meaning they're just limited to the testis. Anatomy: the seminiferous tubules coalesce into the Reedy's testis, which then carry the sperm to the vas deferens. The first echelon draining nodes on the left side from the left testic are para-aortic near the left renal hilum. On the right side, they are aortocaval nodes. With scrotal invasion, please be aware that the inguinal lymph nodes are at risk. Non-seminomas include embryonal, yolk sac tumors, choriocarcinomas, teratomas, and mixed germ cell tumors, which you treat as non-seminomas. The half-life of tumor markers for beta-HCG, beta human chorionic gonadotropin, these are hormone made by syncytial trophoblasts. It's elevated in 10 to 15% of pure seminomas, has a half-life of 1 day. AFP alpha-fetoprotein, which is a protein, has a half-life of 5 days, and then lactate dehydrogenase, which is nonspecific, has a half-life of 3 days. An elevated AFP means you have a non-seminoma tumor. Workup for testicular mass differential diagnosis includes torsion, infection with epididymitis, hydrocele or varicocele. Your H&P generally ask about painless testicular swelling or a mass. Bilateral testicular exam. Look for supraclavicular nodes, gynecomastia. Ask about a history of cryptorchidism, inflammatory bowel disease, inguinal surgery, or horseshoe kidney. Again, labs: beta-HCG should be less than 50. T half-life is 24 to 36 hours. AFP less than 10 is normal. T half-life is 5 to 7 days. LDH 100 to 330 is normal. T half-life up to 3 days. Additionally, get CBC, CMP. Just again, remember, AFP is never elevated in a pure seminoma. If AFP is elevated, as we mentioned down here, you have a non-seminoma tumor. Imaging: you want bilateral Doppler testicular ultrasound. Typically, your tumors are going to be hypoechoic and hypervascular. Post-surgery imaging: get a chest x-ray, get a CT abdomen pelvis postoperatively, get a CT chest if you have a positive CT abdomen pelvis or an abnormal chest x-ray postoperatively. A brain MRI and or bone scan if clinically indicated, meaning the patient has symptoms or lots of lung mets. Consults: fertility assessment plus or minus sperm banking. Pre-radiation sperm counts are low, 40% with azoospermia oftentimes. Other: you never do a transscrotal biopsy or transscrotal orchiectomy secondary to a risk of seeding. TC inguinal biopsy of contralateral testis if suspicious ultrasound, cryptorchid testis, mark atrophy. Radical orchiectomy pathology findings: you want to know the size, what does it invade, and whether or not there's LVSI. Repeat beta-HCG, AFP, LDH. Staging: 5-year overall survival. Pathologic T staging: T1 is limited to the testis, meaning including Reedy's testes invasion without LVSI. T1A is less than 3 centimeters. T1B is greater than or equal to 3 centimeters. Again, T1 limited to the testis, T1A less than 3 centimeters, T1B greater than or equal to 3 centimeters. T2 limited to the testis, including the Reedy's testis, but with LVSI, or alternatively, the tumor invades the hilar soft tissue, or the epididymis, or the tunica albuginea. T3 is spermatocord involvement, and T4 is scrotal involvement. One more time: T1 limited to the testis, T1A less than 3 centimeters, T1B greater than or equal to 3 centimeters. T2 limited to the testis, including Reedy's testes, with LVSI, or invades hilar soft tissue, or epididymis, or tunica albuginea. T3 is spermatocord, T4 is scrotum. Nodal staging: N1, N2, N3. N1 is regional nodes less than or equal to 2 centimeters. So you can have multiple nodes, but as long as they're less than or equal to 2 centimeters, it's N1. N2, regional nodes 2.1 to 5 centimeters. N3, regional nodes greater than 5 centimeters. M stage, M1A, non-retroperitoneal lymph nodes, or lung mets. M1B, non-lung mets. Again, N stage. N1, regional nodes less than or equal to 2 centimeters in size. N2, regional nodes 2.1 to 5 centimeters in size. N3, regional nodes greater than 5 centimeters. M stage, M1A, non-retroperitoneal lymph nodes, lung mets. M1B, non-lung mets. S stage, this is based on post-orchiectomy values. S0 is all normal. S1, LDH less than 1.5 times, beta HCG less than 5,000, AFP less than 1,000. S2, LDH 1.5 to 10 times, HCG 5 to 50,000, AFP 1,000 to 10,000. S3, LDH greater than 10 times, HCG greater than 50,000, AFP greater than 10,000. Note that only 15% of seminoma patients have elevated tumor markers at relapse, so do not use the tumor markers to monitor for relapse in seminoma. Overall stage grouping, stage 1A, 1B, 1S, 2A, 2B, 2C, and stage 3. There is no stage 4. Stage group 1A is T1N0 tumors. Another way to say this, T1N0, stage group 1A. T2 to 4N0, stage group 1B. TNEN0 with increased tumor markers after surgery is categorized as 1S. Again, T1N0, 1A. T2 to 4N0, stage group 1B. TNEN0 with tumor markers after surgery is 1S. N1 disease is stage group 2A, N2 disease stage group 2B, N3 disease stage group 2C. It's very simple. The stage group 2 is broken up into A, B, and C for N1, N2, and 3 respectively. Stage group 3 is METs, S2 to 3 with nodes. In terms of management, for all, you want a radical inguinal orchiectomy with a high ligation of the spermatic cord first, and then the size and reedy test dysphasion are no longer used to risk stratify. If you have a stage 1A or 1B seminoma, meaning the AFP is negative, again, stage 1A is T1N0, stage 1B is T2 to 4N0. First option is surveillance, NCCN. There's only a 15% chance of recurrence for this. It involves an H&P every 3 months times 1 year, then every 6 months times 2 to 3 years, then annually. CT abdomen pelvis at 3 months, 6 months, then every 6 months times years 1 to 3, then annually at years 4 to 5. Again, there's no need for a CT chest. Get a chest x-ray is clinically indicated. The relapse rate is 15% at 5 years. So again, years 4 to 5 get annually. So we'll do this one more time. Stage 1A to B seminoma, AFP negative. This is T1N0 seminoma, T2 to 4N0 seminoma. Option 1 is surveillance, NCCN, 15% of recurrence, H&P every 3 months times 1 year, every 6 months times 2 to 3 years, then annually. The second option is radiation with a para-aortic strip, 20 gray and 10 fractions. If the patient has a remote history of inguinal surgery, then they have disrupted normal lymphatic drainage, so you would do a dogleg field. But given how much tissue is irradiated, you would probably recommend chemo in that case. Radiation reduces local recurrence to less than 5% per TE10 and TE18 trials. Your third option is carboplatin, area under the curve 7 times 1 cycle. This reduces local recurrence to, again, less than 5% per TE19 Oliver. Stage group 2A, so recall, the stage group 2s are nodal disease. 2A, N1, so positive nodes, but per N1 you have regional nodes less than or equal to 2 centimeters. Option for stage group 2A seminoma is radiation. This is NCCN preferred. It's going to be a modified dogleg field, 20 gray and 10 fractions, plus a 10 gray and 5 fraction boost to a total of 30 gray. Your other option is chemotherapy alone, BEP times 3 or EP times 4. BEP is bleomycin 30, etoposide 100, cisplatin 20 every 3 weeks. EP is etoposide 100, cisplatin 20 every 3 weeks. Again, stage group 2A means N1, regional nodes less than or equal to 2 centimeters. Radiation is preferred. Modified dogleg, 20 gray and 10 fractions plus 10 gray and 5 fraction boost to 30 gray. Your other option is bleomycin, etoposide, cisplatin times 3, or etoposide, cisplatin times 4. Stage group 2B, your first option would be kind of chemotherapy alone, NCCN preferred, BEP times 3, or EP times 4. BEP is bleomycin 30, etoposide 100, cisplatin 20 every 3 weeks. Etoposide, cisplatin is EP, etoposide 100, cisplatin 20 every 3 weeks, times 4. Your other option is radiation. In select non-bulky cases in which the lymph nodes are less than 3 centimeters, you do a modified dogleg field, 20 gray and 10 fractions, but now you do a 16 gray and 8 fraction boost to a total of 36 gray. Again, you do the modified dogleg field assuming no prior inguinal surgery. For 2C disease, chemotherapy. For good risk, it's BEP times 3 or EP times 4. For intermediate risk, which is stage 3 with non-visceral pulmonary mets, BEP times 4. For post-chemo residual mass, greater than 3 centimeters, if you have normal markers, do a PET CT at 6 weeks after chemotherapy. If those are positive, resect with retroperitoneal lymph node dissection or give second-line chemo. Increase surveillance, CT abdomen pelvis every 6 months for year 1, then annually years 2 to 5. For non-seminomatous germ cell tumors with elevated AFP, all get orchiectomy. Radiation is reserved for salvage or palliation in non-seminomatous germ cell tumors. 1A, surveillance. 1B, nerve-sparing retroperitoneal lymph node dissection or BEP times 1 to 2 cycles. 2A, markers negative, do nerve-sparing retroperitoneal lymph node dissection or BEP times 3. 2B, markers negative, BEP times 3. If persistent marker elevation, good risk 1, 2, or 3A, BEP times 3 or EP times 4. Intermediate risk or 3B, or poor risk 3C, BEP times 4. 2C plus, BEP chemo. If you undergo retroperitoneal lymph node dissection for 1A to 2B, pathologic N0 or pathologic N1, surveillance, pathologic N2, EP or BEP times 2, pathologic N3, EP times 4 or BEP times 3. Retroperitoneal lymph node dissection for post-chemo residual mass greater than 1 centimeters, no PET needed. If teratoma or necrosis, surveillance. If residual embryonal yolk sac chordio or seminoma, chemo times 2. Evidence, Danish retrospective, N equals 1,954. 1954, that's birthday, seminoma. Median time to relapse, 13.7 months. 74% relapse in the first 2 years. 22% relapse between years 2 and 3. 4% after 5 years. 15-year overall survival is 91.6%. That's the big thing you got to recall from that. 15-year overall survival is 91.6%. Radiation field, the first is MRC TE10 FOSSA JCO 1999, Bob Fosse. Stage 1, seminoma, looking at PA fields versus dogleg, all treated 30 gray and 15 fractions. There was no difference in 3-year relapse-free survival or overall survival, but there's increased pelvic relapse with PA at 3 years, 2% versus 0%. There's less diarrhea, leukopenia, nausea, vomiting, and azoospermia with PA, 35% versus 11%. This is just an RT field. Again, radiation field, MRC TE10, FOSSA JCO 1999. Stage 1, tumors, meaning there's no nodal involvement. Looking at seminoma, para-aortic versus dogleg, all treated 30 gray and 15 fractions. No difference in 3-year relapse-free survival or overall survival, but there's an increase in pelvic relapse with PA at 3 years, 2% versus 0%. There's less diarrhea, leukopenia, nausea, vomiting, and azoospermia with PA, 35% versus 11%. Next, looking at radiation dose, MRC TE18, Jones, JCO 2005. 20 gray para-aortic versus 30 gray para-aortic. Same 5-year relapse-free survival of 97%. 20 gray arm had less acute toxicity, less moderate severe fatigue, unable to work. 6 new primaries were all in the 30 gray arm. Increased dose, increased acute toxicity. Chemo, MRC TE19, Oliver, stage 1 seminoma, 20 to 30 gray para-aortic fields versus carbo area under the curve 7 times 1 cycle. No difference in 5-year relapse-free survival, 95%. Second germline tumor was lower with chemo, 2% versus 0.5%. However, there were higher PA nodal relapses with the carboplatin. Contralateral recurrence was n equals 15 versus n equals 2 for chemotherapy. Technique, CT sim. Simulates supine, arms at side with custom immobilization, legs separated by a rolled towel of the same width as the scrotal shield, CT with IV contrast, clamshell shield on the contralateral testicle, move the penis out of the field, start radiation when the orchiectomy wound is healed. Target is your para-aortic nodes plus or minus ipsilateral iliac, common internal, external iliac to the top of the acetabulum. IMRT is not recommended, 3D conformal APPA. Your para-aortic fields for stage 1A, bottom of T11 to the bottom of L5. The lateral borders traditionally were placed at the tips of the transverse processes or 2 centimeters on the vertebral body, approximately 10 centimeters wide. Your modified dogleg radiation for stage 2A and B, no prior inguinal surgery. Bony landmarks, bottom of T11 down to the top of the acetabulum. Lower medial border from the tip of the contralateral transverse process of L5 to the medial border of the ipsilateral obturator foramen. Lower lateral border from the tip of the ipsilateral transverse process of L5 to the superlateral border of the ipsilateral acetabulum. Boost requires 2 centimeter margins on adenopathy to the block edge. Vascular structures at Penn, they contour the IVC and the aorta from the bottom of T11 to the bottom of L5, then the ipsilateral iliac arteries and veins, common internal external dents at the top of the acetabulum. They do a 1.2 centimeter radial margin on the IVC and the iliacs, 1.9 centimeter radial margin on the aorta. PTV equals 0.5 centimeters. They put the block edge 0.7 centimeters from the PTV to account for penumbra. Boost is GTV plus 2 centimeters to the block edge. Daily KVs. Full dogleg radiation of prior surgery, inguinal surgery. Modified dogleg plus inguinals. Don't recommend this based on how much is irradiated. Would suggest doing chemo instead. Use clamshell. This reduces dose by 2 times. PA equals 1% dose without, 0.5% dose with. Dogleg 2% dose without, 1% with. Transient azoospermia up to 1 year. 50 centigray. Total azoospermia at 1 gray. Sterilization at 2 gray. Constraints, kidney per NCCN D50 less than 8 gray. No more than 50% of each kidney can receive 8 gray or more. If you only have one kidney, D15 is less than 20 gray, meaning no more than 15% of the kidney gets 20 gray or higher. Cord max of 36, small bowel max of 45. Outcomes, relapse-free survival at 5 years is 97%. Overall survival at 10 years is greater than 90%. Cause-specific survival for stage 1 is 100%. For stage 2A and B is 95 to 100%. For stage 2C is 95%. For stage 3 is 85 to 90%. 20% relapse rate in stage 1 seminoma with observation alone at 15 years, but there's a near 100% salvage rate. Toxicity, acute nausea, vomiting, enteritis, fatigue, bone marrow suppression. Give antiemetic prophylaxis. Concern for late toxicity with secondary malignancy. Relative risk is 2 to 3 times. Increased 5 to 10% versus baseline population. The risk of secondary cancer was 16% at 25 years and 23% at 30 years versus the expected 9 and 14% for the general population per Travis JNCI. Chemotoxicity, bleomycin causes lung fibrosis, etoposide causes hair loss and secondary leukemias. Infertility, 1/5 have azoospermia, 1/3 have oligospermia. With the clamshell, 1 to 2% of the primary dose reaches the testis. 25 to 50 centigray of stage 1, 35 to 70 centigray of stage 2. This ignores internal scatter. 15 to 20 centigray is little effect. 20 to 50 centigray transient azoospermia and 20 to 60%, but this returns after 6 to 8 months. 50 to 100 centigray transient azoospermia and 50 to 80%. This returns after 8 to 14 months. 100 to 200 centigrade total azoospermia and 90 to 100% returns 12 to 24 months. Greater than 200 centigrade, 100% permanent sterilization. Try not to have kids for 1 year after radiation. 30% are able to have children after treatment with radiation. Retroperitoneal lymph node dissection risk, retrograde ejaculation causing infertility nerve sparing technique is effective in 95%. Follow-up, stage 1 for surveillance, see management column. Stage 1, status post-chemo or RT, H&P labs optional every 6 months times years 1 to 2, then annually. CT, abdomen pelvis annually times years 1 to 3. Stage 2, status post-radiation or chemo, H&P every 3 months times 1 year, every 6 months times years 2 to 5. CT abdomen pelvis at 3 months, then 6 to 12 months, then annually times years 2 to 3. Chest x-ray every 6 months times years 1 to 2. Stage 2B and 3. Chemo, no residual mass greater than 3 centimeters in size. H&P every 2 months, year 1, every 3 months, year 2, every 6 months, years 3 to 4, annually year 5. CT abdomen pelvis every 4 months, year 1, every 6 months, years 2, annually year 3 to 4. Chest x-ray every 2 months, year 1, every 3 months, year 2, annually 3 to 5. If residual lymph node after radiation, do retroperitoneal lymph node dissection, check to see if it's a teratoma. Let's briefly review the actual fields. Dogleg modified, the superior border is at the bottom of the body of T11. The inferior border is at the top of the acetabulum. The medial border for the lower aspect of the modified dogleg field extends from the tip of the contralateral transverse process of L5 towards the medial border of the ipsilateral obturator foramen. The lateral border for the lower aspect of the modified dogleg field is defined by a line from the tip of the ipsilateral transverse process of L5 to the superolateral border of the ipsilateral acetabulum. Dogleg field 10 centimeter wide in the para-aortic region, and usually covers the transverse processes, upper border of T10 or T11. Left renal hilum is included for left-sided tumors only. At mid-L4 level, the field is extended laterally to cover the ipsilateral and external iliac. Traditionally, the inferior border was placed at the superior obturator foramen, indicated in orange, to include all external iliac nodes. Para-aortic, again, is bottom of T11 to the bottom of L5. Lateral borders traditionally placed at the tips of the transverse processes are 2 centimeters on the vertebral body, approximately 10 centimeters wide. Modified dogleg, bony landmarks, bottom of T11 down to the top of the acetabulum. The lower medial border is from the tip of the contralateral transverse process of L5 to the medial border of the ipsilateral obturator foramen. Lower lateral border from the tip of the ipsilateral transverse process of L5 to the superolateral border of the ipsilateral acetabulum. Boost requires 2 centimeter margins on adenopathy to the block edge.